This is the third part of epilepsy guideline, green top guideline, in which I will mention all the contraception options for the epileptic women who are taking enzyme inducers or non-enzyme inducers. So this is separately very important topic because these points will be asked in the written and the exam part 2 and also in the part 3 exam. So contraception with enzyme inducers, women with epilepsy, we will mention the contraception long term and also the emergency contraception. So contraception with enzyme inducers, women with epilepsy should be offered effective contraception to avoid unplanned pregnancy, because from after reading all the preconception and antenatal care, we have seen that if the patient knows, if patient is in the best of her health and with the monotherapy and the type of anti-epileptic drug, which is having good safety profile, and also we will avoid the polytherapy, and we will have the lowest possible dose of anti-epileptic drug, and also taking folic acid and proper screening in pregnancy, and avoiding the risk factor like sleep deprivation and insomnia, dehydration. All these factors and avoiding stress will result in better outcome in pregnancy for the mother and the baby. So for the so we want the contraception, want to have effective contraception in patient with epilepsy to avoid unplanned pregnancy. So women taking enzyme-inducing anti-epileptic drug, carbamazepine, phenytoin, phenobarbital, pyrimidone. So all these drugs, topiramate and oxycarbazepine, should be consulted about the risk of failure with some hormonal contraceptives. Women should be consulted that efficacy of oral contraceptive, combined hormonal contraception, and progesterone-only pill, transdermal patches, vaginal ring, and progesterone-only implant may be affected with enzyme inducers. So all the hormone-containing contraceptive choice will be affected with enzyme inducers. So expected failure rate for oral contraception is 3 times higher in women with epilepsy taking enzyme-inducing anti-epileptic drug compared to with the normal population. So you will see in enzyme inducers, the oral contraception will fail. But with the lamotrigine, if we take with the oral contraception, then it will not fail in the contraception. It will increase the risk of fits. But in the enzyme inducer, there is a expected failure rate of oral contraception is 3 times higher in the woman with epilepsy taking enzyme inducing anti-epileptic drug compared with normal population. Levonorgestrel intrauterine system and copper coil, medroxyprogesterone acetate with enzyme inducer UKMAC1. So they have 3 options. Local, LNGIUS is a local option of hormonal contraceptive, and copper coil, medroxyprogesterone acetate. These with enzyme inducer UKMAC1. So in injectable, we have 2 options, medroxyprogesterone and norethindrone. So medroxyprogesterone is UKMAC1, but progesterone only implant and norethindrone are UKMAC2, and progesterone only pills and combined oral contraceptive pill are UKMAC3. So they will ask whether patient is having this type of, say patient is having carbamazepine, so what option is better for her? So they will give which one is a UKMAC1. So UKMAC2, we know that in the UKMAC2, we can say that patient is, the benefits are more than the risk. So first is the UKMAC1, and if UKMAC2 is also acceptable if because the patient refused to take UKMAC1. So contraception with in women who are taking enzyme inducer and choose to use oral contraception, then the contraceptive efficacy may be improved. So now we have seen that progesterone only pill and COCP are UKMAC3. But patient says that I don't, I have used it previously, or she will say I have failure of contraception. I don't want to do this, and I'm totally convinced that I want to have combined oral contraceptive pill, because you tell her all the pros and cons of combined hormonal contraceptive and advantages of other copper coil and NGIUS. She says, I don't want anything intrauterine or whatever her concern. She refuses all other methods. So she chooses to have a progesterone only pill and COCP. We know that we will take it with an enzyme inducer. There is a risk that this will fail the contraception and she will have unplanned pregnancy. But she is consistent that she will have progesterone only pill and COCP. So we can tell the patient about the pros and cons, and we will tell that if you want to have, then contraceptive efficacy may be improved. It's not we are confirmed about that. So we can give her the option that so we will tell the patient that we increasing the estrogen component to 50 microgram and maximum up to 70 microgram. We can increase the either we can increase the estrogen component, or there's also option of reducing the pill-free interval from 7 days to 4 days. Instead of having pill-free interval for 7 days, we will reduce it to 4 days, and or tricycling, taking 3 packs back to back. So we can have these options. So this is the long-term contraception. For the emergency contraception, we know that for the emergency contraception, we have 3 options. We have copper coil, levonorgestrel, or uripristal acetate. For the copper coil, it can be given for, we can have copper coil if the patient is within 5 days, or uripristal acetate for the 5 days, and levonorgestrel for 120 hours. And then we will levonorgestrel for 3 days, and ulipristal and copper coil for the 5 days. So we will give the option of, we have option of copper coil and levonorgestrel and ulipristal acetate. Patient gives a history of epilepsy, so we will ask her, what anti-epileptic are you taking? If she is taking enzyme inducer, then we will give her the option of copper coil, which is best, and we can say we can have this. And also it is the best among all these 3. And moreover, you can continue it for the long-term contraception as well. But if patient refuse for copper coil and she is insisting that she want to have oral medication, so ulipristal acetate should not be given in this patient, but levonorgestrel dose should be doubled. 3 milligram will be given to this patient. So next is the contraception with the in non enzyme inducers. So all methods of contraception may be offered to women taking non-enzyme inducing anti-epileptic drug. For example, sodium valproate, levetiracetam, gabapentin, vigabatrin, tiagabine, and pregabalin. So these are all are the UKMAC1 in the non-enzyme inducers. You can have all the option POPs, COCP, and injectables, LNGIUS, copper coil. She can have all the options. But for the emergency contraception, she also has entitled to have all type of emergency contraception in the normal dose. But for the contraception in women taking lamotrigine, so women taking lamotrigine monotherapy and estrogen-containing contraceptive should be informed of the potential increase in the seizure due to fall in the level of lamotrigine. So is worsening of epilepsy. It does not result in contraception failure. It does not result in contraception failure, but result in increased seizure. POPs, progesterone-only implants, progesterone injectable, copper coil LNGIUS are UKMAC1, so COCPs are UKMAC3. Other implications, these are very important to tell the patient that fact of changing the dose of anti-epileptic drug on seizure and its impact on driving privileges, because if she has uncontrolled epilepsy, then it will affect her driving privileges. Stopping or reducing the dose of anti-epileptic drug in pregnancy may result in seizure deterioration, including the first episode of seizures. This will have an impact on driving privileges and may affect parenting and work plans. Healthcare providers need to be aware of the equality legislation, Equality Act 2010, in the UK that protects individuals with a disability from discrimination. Thank you so much. Is there is any other question? So kindly write down in comments.